Welcome, dear all, for this episode of NephroTube Nephropathology series. This is the fifth episode. It's our pleasure to have Dr. Sarah Hassan. She is the head of electron microscopy department, Theodore Bilharz Research Institute in Egypt. She will talk today about membranoproliferative glomerulonephritis and C3 glomerulopathies. We all know that this is an important topic and has a lot of differential diagnosis. So I hope that after this lecture, all the different aspects regarding the pathology will be clear for all of us. Please, Sarah, the floor is yours.
Good evening, everybody. I hope you are all okay. Today's lecture is very important, I think, and has so much to be clarified, especially in the pathogenesis, not only in the morphology. And any comment is more than welcome. So please try to interact more than any lecture before, and let's start. The agenda of today will include a definition of membranoproliferative glomerulonephritis and how does the morphology of MPGN evolves with some case presentations, and what's complement pathway and how do these pathways function, and why should we understand this pathway? Either you are a pathologist or a nephrologist, do you have to understand it and go back to the physiology of the undergraduates to know this common pathway? Yes, I think it's very important to understand it for pathologists and nephrologists to understand the role of immune staining markers, because these markers are just antibodies that highlights what's deposited here, which are the components of the complement pathway. So you should understand what's going on physiologically to know what are you interpreting and to have a clear diagnosis and to try to choose the next step. What's the lab investigation you have to do? Either you are a nephrologist or for pathologists to have a beneficial comment in our report. And the last point that we will talk about is the role of C3 in both TTP and HUS, and this is a very important topic and could be not very well understood by some of us. Sometimes I get confused about the role of C3 in both TTP and HUS. So let's start. First, we should know, and I think that most of us know, that MPGN is a pathological pattern and not a disease. With many underlying diseases may be present and all have the same light microscopic picture, and electron microscopic examination and immunostaining differentiate between these underlying causes, and the electron microscopic picture is very important. And that's the MPGN, the classic MPGN that we know with the mesangial hypercellularity, glomerular
Sarah, your sound is not clear. Your voice is not
double
clear.
contouring,
Sarah,
and the electron microscopic picture of the
Sarah,
glomerular basement membrane double contours with the endocapillary
Sarah,
hypercellularity, as we see here.
Sarah,
The
can you hear
glomerular
me,
basement
Sarah?
membrane is split. My sound is
Sarah,
low.
لا الصوت بيقطع.
Dr. Muhammad, what is the problem?
الصوت
You hear me?
بيقطع جامد.
صوت بيقطع. انا سامعك كويس جدا.
Yes, we missed
طيب كده.
the last 30 seconds. We couldn't hear you well.
Starting from
Can you
where?
repeat the
Can you hear
previous
me
two
now?
slides? Yes, the
Can
previous
you hear
two
me now?
slides. Yes, I can
Okay.
hear you.
Okay, let's be back here.
Back,
This
yes,
slide.
please.
This slide.
There is a problem with your connection. Even the slides are moving very slow. Yes. Back another slide. Yes, this one of the double contouring and mesangial hypercellularity.
Okay. I think that we will have a problem today with the internet connection. It seems it's poor. Can you hear me now?
Yes.
Okay. Please, if any interruption occurs, tell me.
Okay.
Okay, that's the classic MPGN with the mesangial hypercellularity and the glomerular basement membrane double contouring. Okay. Okay, Dr. Muhammad, okay?
Okay, yes, yes.
Okay. And the electron microscopic picture of the glomerular basement membrane double contouring and the endocapillary hypercellularity, and the lumen, as we see here, is no more patent. It's filled with cells. Some of them are inflammatory cells and some are the proliferating endothelial cells. Okay. Again, endocapillary hypercellularity with polymorphs, as we can see here. Let's start with the pathogenesis of MPGN, pattern of injury. The connection is okay?
Yes, yes.
Okay. First, endothelial injury occurs, and that's the first event, followed by accumulation of plasma-derived material in the subendothelial space, and this causes irritation of the glomerular basement membrane to form new basement membrane material, and ends up with the double contouring of the basement membrane. So an injured endothelium. And if we go back to the first lecture, we will revise back that injured endothelium means that the endothelium loses its fenestration and becomes a continuous layer
Sarah,
of cytoplasm,
Sarah,
and
the connection is bad, Sarah. Sarah, can you hear me? Sarah, can you hear me, Sarah? It seems that
okay, that's the subendothelium.
Sarah,
Mm.
we
Okay, I
lost
try
your
to
voice.
go somewhere. Me, Dr. Muhammad.
Now I
Okay,
can
I
hear
try
you,
to choose another way.
but hmm?
I can hear you.
الصوت بيقطع يا سارة. We lost her. We will give her 1 minute to be back. I hope that she will find a good connection.
Muhammad, I'm back. Can you hear me now?
Yes, I can hear you, Sarah. You can
Okay,
start
I
now.
hope the connection is better now. Let's try again.
Your voice is clear. Please continue.
Okay. So let's continue. So the endothelial injury causes accumulation of plasma-derived material in subendothelial space, and irritation of the glomerular basement membrane ends up with the double contouring. So endothelial injury could be due to deposited material that may be in immune complexes or complement components, C3G, in C3G, monoclonal proteins, or other organized deposits. And could be an endothelial injury with no deposits as a secondary to hypertension in cases of TMA. It's another type of MPGN. So MPGN is a pattern. So what do these patients suffers from? As we have said, that immune complex mediated injury may be the cause, an autoimmune disease like systemic lupus, or infection, either chronic infection as HCV, and maybe also an acute infection as post-infectious GN, which is mostly typical. So it could be chronic or acute, and in both cases, it's a healing process, either in the acute or in the chronic post-infectious case, chronic post-infectious or infection-related injuries. Let's discuss our first case for today. It's a 30 years old male. He was an HCV positive and impaired renal function, and his first biopsy was in 2016 and showed a membranoproliferative pattern of injury. The patient received antiviral therapy and didn't complete his course. 5 years later, he presented with serum creatinine 4.5, AC ratio 1.9, and his C3 and C4 was consumed. So his second biopsy showed an MPGN pattern of injury with advanced segmental and global glomerulosclerosis occupying 65% of his glomeruli, and IFTA of 40%, and his immunohistochemistry showed C3 dominant deposit. And that's his electron microscopic picture showing subendothelial deposits. Even in sclerosing glomeruli, segmentally sclerosed glomeruli, the deposits are seen. So the diagnosis was C3 dominant MPGN, mostly secondary to chronic HCV with secondary focal segmental glomerulosclerosis 65% and IFTA 40%. Second case was for a 6 years old female with history of upper respiratory tract infection and rapidly progressive GN serum creatinine of 10, proteinuria, and light microscopic picture of acute diffuse proliferative GN with crescents 50%. And immunohistochemistry showed C3 dominance again with the electron microscopic picture showing subepithelial humps and some intramembranous deposits. So that's an acute diffuse proliferative, acute, but C3 dominant with active crescents 50%. And this case, the follow-up of his serum C3 level is recommended to exclude the possibility of atypical post-infectious or C3 GN if this course of the disease prolongs. And this will be discussed with later on with the pathogenesis of C3 GN. Under electron microscope of this case, we have seen early evolving double contouring, but just on the ultrastructural level, not on the light microscopic level, So it's not the extent to say that that's in an MPGN. But what we would like to say here, that the healing process is the evolving and the start of evolving of the double contouring of the glomerular basement membrane. So double contouring is just the healing process of the resolved immune complex, the dissolved or resolved immune complexes, and the healing of the membrane that will heal in an irregular shape that could be thickened, could be double contoured. So it's just the process of healing. And according to the extent, it's called MPGN when it appears under light microscope. So another cause of endothelial injury is the complement dysregulation and C3 glomerulopathies, which are which include the
Sarah,
deposit disease.
Sarah. Sarah.
And
Yeah, Sarah.
C3 glomerulonephritis.
Sarah.
Can you hear me, Dr. Muhammad?
No, there is interruption in your connection again. We we uh, we cannot hear you now, sir. We cannot hear you if you are hearing us. If we lost Dr. Sarah today, I will ask her to record the lecture and I will upload it on YouTube, inshallah. But we'll give her another chance, inshallah. I'm waiting here.
Okay.
Yes, Dr. Abdul Hamid, you can ask. تفضل. Okay, Sarah, you can.
I'm sorry for this interruption. I don't know what's the problem. I'm
I
trying
hope
to
that
another.
we'll not lose you again, inshallah.
I hope.
تفضل.
Okay. So, complement dysregulation could be another cause. C3 glomerulopathies, dense deposit disease, or C3GN shows C3 only or dominant. So we can have IgG as well with C3, but C3 will be more dominant. Both dense deposit disease and C3GN have overlapping features together. Under light microscope, MPGN could be the light microscopic picture and could be other light microscopic patterns as messenger proliferative endocapillary hypercellularity with polymorphs or focal necrotizing GN even. So light microscopic picture does not show that that's a C3 glomerulopathy. Let's go to this case because I'm afraid of the connection. It's a case of 9 years old female hematoric, 60 per high power field, proteinuria 3 plus, and serum creat 1.1. Her light microscopic picture is MPGN with crescents 20%. and some neutrophils as well, and that's the mesangial expansion with hypercellularity. And under Masson trichrome, we can see the thick glomerular basement membrane with a refractile intramembranous deposits. And immunohistochemistry shows the diffuse glomerular basement membrane C3 immunohistochemical deposits, and the IgG shows some endothelial non-specific deposits, so it's negative, and the EM shows the electron microscopic and the electron dense transformation of the glomerular basement membrane without the discrete immune complex type of deposits, and that's at higher magnification with electron dense transformation of the glomerular basement membrane, which is characteristic of dense deposit disease, the transformation, which means that the glomerular basement membrane is transformed, totally transformed into this electron dense material of dense deposit disease. So that's a picture of dense deposit disease. Another picture, classic picture of dense deposit disease with electron transformation of dense deposit of the glomerular basement membrane. This transformation could occur also along the tubular basement membrane. That's the normal tubular basement membrane, and that's the transformed tubular basement membrane, and could occurs also along the Bowman capsule. So dense deposit disease is not an uncommon disease and mainly presents with hematuria, and C3 deficiency is more common in the pediatric age group. The classic complement pathway components, which are the C1q and C4, are usually at their normal level, unlike C3, which will be deficient. Some of these patients present with partial lipodystrophy and ocular dozens, and 30 to 40%, 50% progress to end-stage renal disease within 10 years, and 60 to 85% recurs post-transplantation. So it's a serious diagnosis, and it's diagnosed only by EM. Okay. البور prognostic factors for the histopathologic point of view is the presence of crescents and the presence of polymorphs in his renal biopsy. Another case of 10 years old male with history of tonsillitis 3 months ago, serum creat 1.8, hematuria, C3 consumed, and light microscopic picture of MPGN with polymorphs. So these are the polymorphs, and that's the glomerular basement membrane with some rarefactions here, or these clear areas, we call it rarefactions. Another field showed what? Showed subendothelial and mesangial deposits. These are deposits. These are deposits. But this is not the classic transformation of the total glomerular basement membrane as we have seen in the dense deposit disease. And they are not also the classic globular immune complexes of the immune complex deposits, but some are globular here, but most of them are cylindrical and slightly or fluffy electron dense with no transformation of the glomerular basement membrane. Again, cylindrical, slightly fluffy deposits, and again, the same description. Some subepithelial humps were present as well. So, what's the diagnosis? First, the immunohistochemistry showed also C3 dominance. And these deposits were present also in segmentally sclerosed areas of the glomeruli. That's a picture of C3GN. Why that's a C3GN? Because of the description that I have just said about the deposits. These deposits are C3 by immunohistochemistry. These deposits are not the classic transformation of the glomerular basement membrane. These deposits are more fluffier than the deposits that we usually see with the immune complexes, and more cylindrical in shape, and it's not a transformation. So, and subepithelial humps are present as well, which is okay with both dense deposit disease and C3GN. So this is more towards the picture of the C3GN, and it's not a typical post-infectious. If we are back to the history of this patient, which had a tonsillitis 3 months ago, so the natural history of the disease is prolonged, plus the description of the deposits, so that's it's not a typical post-infectious GN. It's more with C3GN. I hope this is clear.
Yes, it is clear.
Is it clear, Dr. Muhammad? And
Yes, clear. It is very
I
clear.
hope connection is better.
Yes,
Okay.
it is good.
So, what are the triggers of C3 glomerulopathy? First, infections. Initial clinical picture is post-infectious, as the last case. An initial biopsy could be diffuse proliferative GN, but with more sclerosing in the biopsy, we would be more worried about the atypical course of the disease. Immunostaining, strong C3 and lesser IgG, and that's a picture of a acute diffuse proliferative GN with polymorphs. So the follow-up will show us a prolonged clinical course and persistently low C3, serum C3 more than 6 to 8 weeks, and electron microscopic picture of C3. Okay. The second trigger could be monoclonal proteins, which is more in the older ages. And proteins triggers this by activating the alternative complement pathway leading to C3 glomerulopathy. And under the light microscope or in the biopsy, we will not see monoclonal proteins deposited, just the triggered complement pathway causes the injury, and no evidence of monoclonality will be present in the biopsy. And these patients will achieve remission for his renal affection with their chemotherapies that will achieve also his hematological remission. C3GN, what's the difference between C3GN and dense deposit disease? Microhematuria is the most common presentation for both. C3 will be low also in C3GN. It has a less incidence of progression to end-stage renal disease, but similar incidence of recurrence post-transplantation in both C3GN and dense deposit disease. So complement dysregulation and C3 glomerulopathies and monoclonal IgG deposition at MIDD in the case of MIDDs, if we have talking about the monoclonal proteins that could triggers the complement pathway, and this complement pathway or triggers complement pathway causes the injury without deposition of monoclonal proteins. But in another story, these monoclonal proteins may deposit by themselves, causing MIDDs and cause the membranoproliferative pattern of injury. And in this case, the monoclonal proteins will be found in the biopsy. So there is an interaction between dense deposit disease and monoclonal gammopathies in a subset of patients. And if you have an adult patient with dense deposit disease, you should exclude the presence of monoclonal gammopathies and monoclonal proteins that were not detected in his renal biopsy, but just triggered his complement pathway. And I hope this point is clear. And if anyone have any comment, I'll be glad to comment to answer his question or comment. Okay, the last two triggers of endothelial injuries, chronic TMA and transplant glomerulopathies, which are another picture of membranoproliferative GN. And last case in this half of the lecture is for 10 years female non-lupus that present with hypertensive encephalopathy and serum creat of 3.2. Here light microscopic picture showed no inflammatory cells, and the glomerular basement membrane double contouring was found. In these cases, we will mostly think about lupus activity. Why this patient had a high serum creat? but no activity was found and no deposits was present. And under under electron microscope, just an injury with subendothelial accumulation of plasma proteins and early glomerular basement membrane double contouring, and again no electron dense deposits were found. So the picture of TMA, which is probably secondary to an accelerated phase of hypertension, and no lupus activity in this case. And hypertension may also causes severe endothelial injuries that may lead to collapse, glomerular capillary collapse, as we have seen here in this collapsed and irregularly contoured glomerular basement membrane. Okay, now that's the important part that I think in this lecture, which is the physiology of, or the what's the why we are using these antibodies in immunohistochemistry. And as I have said, we have to revise what's the complement system. The complement system is the innate or the first line of the immune system that targets injured or dead tissue. Is a proteolytic cascade of 40 proteins. It is present in the blood, and that's the fluid phase, or expressed on the cell membrane, and that's the solid phase. So it's a proteolytic cascade. One component with a proteolysis or proteases causes activation of another component, and one after the other. And what's the function of this system? The final step or the target of this system is a membrane attack complex, or MAC, that's formed by assembly of C5 with C6, 7, 8, and 9, and kills the cell by forming membrane lytic pores, which is the end of this cascade. Okay, the second function is opsonization, which is made by C3b labeling of the target cells for foreign bacteria or self but non-viable cells, and interact with the acquired immunity and cause removal of these opsonized cells. Okay, so let's revise this common complement pathway component, which is the C3 that have its antibody or in immunohistochemistry, and C5 complement and their convertases. C3 is always, C3 convertase is always primed, normally always primed, always active. And this activity, as we have said, is a proteolysis, causes proteolysis or break in C3 into this C3a part and C3b part. Two factors are called factor B and factor D. Factor B will binds to the C3b part of the converted C3 or the active C3, and factor D will catalyze the reaction and causes degradation of factor B into two parts, again BB and BA. The BB part will combines with the C3b component, forming the C3bb, which will recruit more C3b, and this ends up with the formation of C5 convertase that will recruit more complement components from C6 to C9, which are the MAC or the membrane attack complex. So factor B again is divided into factor B and BA. This BB will combines with the C3b, forming C3BBB, which is a C5 convertase of the common complement pathway. Why common? Because if we go back to the complement system, we will see that these are three pathways: classic pathway, lectin pathway, and alternative pathway. All of these ends up at the level of C3, whatever the target, whatever the initiation is. In the classic pathway, antigen antibody complex will be the initiating factor. In the alternative pathway, an injured or dead tissue will be the initiating factor, and lectin pathway as well. All will end up at the C3 level. So at the C3 level here till down, we are in a common complement pathway. And that's a very important issue to put in mind. Okay. Now, the third and the last function of complement system is the anaphylatoxins, which in which the fragments that C3A and C5A are responsible for this action for mediating local inflammation and promoting chemotaxis. So C3A and C5A are these factors, and are important factors to put in mind for the next slides. Okay, although complement requires activation to mediate the biological function, this is always primed, as we have said, so this needs an active control to prevent self-damage. C3 convertase, which is always primed, needs a factor to stop its continuous activity, which is called factor H. So under normal conditions, factor H controls or stop C3 activation. The function of factor H is eliminated in the presence of pathogens or injured tissue, causing the common complement pathway activation, and in the presence of mutation or antibodies against factor H, more alternative complement pathway or more common complement pathway activation will occur. The only positive regulator that increases or stabilizes the activation of C3 convertase is known as proburden. Okay. Some analysis or serum analysis are needed to check for the complement system activation, and it's beyond the traditional check of C3 and C4. Both C3 and C4 will both C3 and C4 will be reduced in immune complex mediated diseases, and that's very important to combine between C3 and C4. C3 will be low, especially if associated with C3 nephrotic factors in C3GN, dense deposit disease, atypical post-infectious, atypical post-infection, and atypical HUS, TTB, and chigatoxin-induced HUS. And let's have a question: why TTB? TTB is not a complement-mediated disorder. Why C3 will be low in these cases? It's okay for a typical HUS and also for chigatoxin-induced HUS. Why C3 is low in this case? And we will have the answer in the next slides. It will be significantly low. C3 will be significantly low alone without reduction in C4 in mutations of the regulatory factors as factor H or factor I. Okay, the lab analysis will show the functional and activity test for the complement pathway components. Individually, the components could be tested, and we could quantify these components and check its quantity or its activity. The first test, generally, we speak have a generally speaking about these tests. They test the ability of the complement system to induce lysis of RBCs. That's the general speaking. A normal value does not exclude the presence of dysfunction in individual components of the complement cascade. The most commonly used assay is called total hemolytic CH50 assay, and it screens for all components where pre-coated antibodies, erythrocytes with antibodies will interact with the patient serum to induce lysis. Why antibodies? Antibodies means antigen antibody reaction, which means the classic complement pathway, and that is triggered with antigen antibody reaction, where the first component will be C4. So in this case, C4 will be used, so will decrease in its amount and ends up with the MAC system. Okay, it could be low in the congenital deficiency or increased consumption. Consumption with increased acute flares of immune complex mediated disease or classic complement pathway activation, and or in insufficient synthesis of complement factors as in hepatic diseases. The second test is called the alternative pathway assay. This this test tests the complement ability to induce lysis of the RBCs as well. The higher the activity of the alternative pathway, or means lower amount of patient's serum needed to hemolyze the RBCs. And again, if it is consumpted due to an flare of immune complex mediated disease, more serum will be needed, and this the effects on the regulatory proteins at factor H could means consumption of this common complement pathway components and leads to defects in the regulatory protein. Okay, consumption of the complement proteins from a classic pathway activation, which means antigen antibody complex, will end up in the common complement pathway activity, which is the C3. So we could have an immune complex mediated disorder as post-infectious GN. It is an antigen antibody reaction, but we have a low C3. Why? Because that's the common complement pathway. Is a common complement pathway which could starts with antigen antibody complex but ends with C3 activation and deposition in the tissue, and this will reflect with the immunohistochemical results with C3 dominant deposits. So the classic post-infectious GN, in the classic post-infectious GN, we may have a C3 dominant deposits by immunohistochemistry, which does not mean that this is a C3 glomerulopathy or a dense deposit disease. The dominance of C3 by immunohistochemistry does not mean that this is a dense deposit disease. Dense deposit disease is an electron microscopic diagnosis. How to diagnose or how to distinguish between complement pathway dysfunction, normal C4 level and normal CH50 in the presence of low AP50 means consumption confined to the alternative pathway. Whenever the C4 is normal, this means that there is no antigen antibody reaction and that C3 is activated alone. So it's not an immune complex mediated GN. So the normal C4 here is very important. Okay, let's go through this slide and say what's the renal disorders caused by alternative pathway, complement pathway dysfunction. First, atypical HUS, post-infectious but atypical post-infectious, which is a prolonged course with persistent hematuria, proteinuria, and even development of end-stage and C3 glomerulopathies, as we have said before. Let's discuss what's the difference between atypical post-infectious GN, C3 GN, and dense deposit disease. I think that the difference is not clear till now. All have alternative complement pathway or common complement pathway abnormalities that could be triggered by infection as a first step. And by immunohistochemistry, unfortunately, we cannot differentiate between them. C3 deposits are mostly dominant even in typical post-infectious GN. By light microscope, the atypical post-infectious is just like typical diffuse proliferative GN, but maybe in the C3 GN and dense deposit disease, the course of the disease is more rapid and goes more to the chronicity with more MPGN, and as I think that MPGN is more a chronic pattern of injury, because this means that the glomerular basement membrane is markedly injured, and this triggered the formation of the double membrane and the glomerular basement membrane double contouring. So it means that it is markedly injured, and the rapid process that causes this healing MPGN pattern with more segmental sclerosis probably. In dense deposit disease may be totally exudative GN that is very misleading under the light microscope, and as we have said, dense deposit disease is an electron microscopic diagnosis. So atypical post-infectious GN, maybe C3GN with time. And unfortunately, I don't think that there's a clear cut between them under light microscope. More as I have said, that MPGN is more in C3GN, more subendothelial deposits and more mesangial deposits, with the characteristics that I have said of the more cylindrical and more fluffier and early glomerular double membrane contouring. So that's important to say. And this means that these cases needs a follow-up clinically and follow-up with their serum C3 and the lab analysis that we have said about the complement pathway factors and the factor H abnormalities, and if there's any antibodies or congenital or mutations in these factors. So it's not always the biopsy that gives the final diagnosis or the final answer, except for dense deposit disease, actually. Okay. And a very important topic is a TMA that we have discussed before, which is a pathological lesion in which the endothelium is injured with intraluminal thrombosis. And the major forms of TMA are TTB and HUS. What's the difference between TTB and HUS? TTB is associated with the deficiency of ADAMTS 13, which is a von Willebrand factor cleavage proteases because of mutation or autoantibodies against
Sarah, we cannot see this
HUS
slide.
could be.
Sarah?
You
Yes,
cannot
it
see
is
this
clear.
slide?
Yes, it is clear now. Yes, I can see it now.
Okay, clear?
Yes.
HUS could be Shiga toxin associated or atypical complement mediated atypical HUS. Endothelial injury occurs in both TTB and HUS, but in TTB it is secondary endothelial injury due to the release of the ultra-large von Willebrand factor with its high potency to bind platelets, and this leads to the endothelial injury and the thrombosis. So it's a secondary endothelial injury due to the thrombosis. But in HUS, in both typical and atypical HUS, it's a primary endothelial injury, either due to the Shiga toxin or due to the complement deposition. What does this mean? This means that in TTB injury, the endothelial injury, as we have said, that the trigger of the alternative complement pathway is what? Is a pathogen, bacteria, or a self-antigen, but injured self-antigen. So self-injury promotes the alternative complement pathway and thus the C3 activation. So TTB is not a complement dysfunction. It's not a dysfunction in the complement system, but the injury that occurs in the endothelium causes C3 deposition, which is the normal physiology of our bodies. So when, as for me as a pathologist, I order for C3, I have a case of TMA, and by immunohistochemistry, I found C3 deposition. Does this mean that this is a case of atypical HUS? No. TTB could have C3 deposition as well. And that's an important point that I wanted to declare, and I hope it is clear. Also, in Shiga toxin, which causes endothelial injury, complement pathway will be activated as the normal process occurs. In atypical HUS, the system is always active, which is abnormal and causes C3 deposits as well. So in the three cases, C3 could be deposited, and that's an important point to highlight. And when you are reading a report or histopathology, nephropathology report, and found C3 deposits, we should go back to the underlying pathogenesis, why C3 is deposited in this case. I hope I made it clear as much as I could. So regardless of the cause, TTB, Shiga toxin, HUS, or atypical HUS, complement activation will contribute to the thrombotic process through enhanced platelet activation and endothelial injury, and thus sustain the microangiopathic lesion. And this was a paper. I hope we can go back and read it, that used C4D. I hope I think that all of us know C4D. C4D that we use in transplant biopsies to detect the antibody-mediated rejection. This C4D is just the C4D of is just part of the C4, which is one of the components of the common complement pathway, which is activated by antigen antibody reaction. So C4 and C4D, C4 or C4D, denotes what? Denotes antigen antibody reaction of the classic complement pathway. So whenever we have a C4, low C4 in the serum, or C4D stained by immunohistochemistry, this means that the common complement pathway is activated, which means that it's not a complement pathway dysfunction, because the complement pathway dysfunction affects what? Affects the common complement pathway that starts with the C3, just the C3. So, and in these cases, C4 or C4 in the serum will be normal, and C4D in the immunohistochemistry used in the renal biopsy will be negative. So this paper was talking about C4D as a diagnostic tool to classify MPGN. How patients with true C3G are negative for C4D by immunohistochemistry. Some of our professors say that it's not 100% true or not 100% accurate, but till now, I think that at the level of nephropathology, that's that's a very or the tool that we have to try to differentiate between a true C3 glomerulopathy or a true complement pathway dysfunction from C3 deposition due to activation of the common complement pathway that we have talking about in the previous pictures, to use C4D. If C4D is positive, and it's more sensitive than IgG, which is IgG is the antibody. So someone may tell that may say why you can use IgG with the C3 as the IgG is the antibody, which as an antigen antibody reaction, denoting antigen antibody reaction. But I think that C4D is more sensitive than IgG. The last slides we're talking about the C3 nephrotic factor, which stabilizes the C3 convertases, causing its continuous activation. And I thank you, and I hope it was a beneficial lecture. Sorry for the interruptions that occurred.
Thank you, Sarah, for this illustrative lecture. Actually, you covered the topic from many points of view. And I want to highlight more the importance of staining for C4D in the biopsy, especially in cases with membranoproliferative glomerulonephritis, because I think in my little experience in this area, that in some rare cases, patients who has monoclonal gammopathy associated with MPGN may present with isolated C3 deposits with no staining of immunoglobulin. I think this is called masked deposits. And to elaborate or to find these masked deposits, immunofluorescence on formalin fixed or paraffin embedded tissue after pronase digestion is important to reveal these masked monoclonal immunoglobulin deposits. And what raises the suspicion for the presence of these masked immunoglobulin deposits, the presence of C4D, as you mentioned. The presence of positive C4D staining in the absence of immunoglobulin deposits raises the suspicion of masked immunodeposits that we have searched for, because missing these masked monoclonal immunoglobulins can lead for sure for misdiagnosing these patients as having C3 glomerulopathy, and the failure to diagnose the underlying monoclonal gammopathy, and for sure with loss of the direction to the correct management. So this is one of the most important tricks, I think, in the MPGN, besides the different tricks that you mentioned, how to differentiate between C3 glomerulopathy and post-infectious glomerulonephritis or glomerular disease. I think the site of the deposits, the shape of the deposits, and so on. And also, from the clinical point of view, if you are not sure regarding your diagnosis, if the case is C3 glomerulopathy or post-infectious glomerulonephritis, clinically, if there is persistent or recurrent glomerulonephritis in the patient, this is more common with C3 glomerulopathy than post-infectious glomerulonephritis. This is for clinical differentiation rather than the shape of the deposits and the site deposits. And also Dr. Khadija Habshi from Algeria mentioned the same point as you in the comments regarding the shape of the deposits to differentiate between C3 and post-infectious. And I want also to stress on that post-infection may precipitate C3 glomerulopathy. So there may be infection associated with C3 glomerulopathy, but the pathology is C3 glomerulopathy. Or it may be only post-infectious glomerulonephritis. It depends again on the differentiation that you had mentioned in the slides. And the last point that I want to stress on, that any patient with a C3 glomerulopathy and aged more than 50 years or more, monoclonal gammopathy should be excluded. Do you agree on this, Sarah?
I totally agree. I have mentioned it
Yes, I know.
in one
But
of the slides.
Yes.
And I agree with this.
Yes.
Because dense deposit diseases
Yes,
is
yes,
mainly
continue,
a pediatric age group.
Yes. Any patient with with age of 50 years or more with nephrotic syndrome or with C3 glomerulopathy, in these patients we should exclude monoclonal gammopathies.
And I want to stress on the point that the absence of monoclonality or monoclonal restriction in the biopsy does not mean that this patient is free of monoclonal gammopathies or monoclonal related disorders. Even in cast nephropathies, monoclonal restriction may be absent. And for myself, I rely on the light microscopic picture of cast nephropathy more than relying on the monoclonal restriction by immunohistochemistry because it could be missed.
Yes.
So do not rely always on the immunohistochemistry.
Yes. The last 2 points to close the session, I want to mention that idiopathic immune complex mediated peripheral glomerulonephritis is not common in adults. We have always to search for a cause. Even if you didn't find a cause, you have to evaluate for complement dysregulation even in the presence of immunoglobulin immune complex deposits in PGN. Because in some cases, C3 glomerulopathy may present as an immune complex mediated MPGN, especially if it is triggered by infection. So if there is no clear evidence of cause for immune complex mediated glomerulonephritis, and you have immunoglobulin deposits in the biopsy, you have to search for C3 glomerulopathy. What do you think about this point, Sarah?
I think I totally agree with you, Dr. Muhammad. I think that the only diagnosis that we can say it is a C3 glomerulopathy is the dense deposit disease, which is diagnosis as by EM, which is an electron microscopic diagnosis. But any of the other titles that we have talking about during all the lectures, the C3G, C3GN, or C3G, or atypical post-infectious, all can overlap. The only diagnosis that we can swear that it is the diagnosis is the dense deposit disease. And as I said, it's an EM picture. So we just tell what we see under the light microscope, if there are crescents and the percentage of crescents and the relation between this percentage and the prognosis of the patients, as we have said. But you have to complete your investigations with the lab analysis, the serum analysis, as we have said. And I think that most of these factors have commercially available serum tests now. Of course, you know better than me. I tried to search for this because I really found that that's very confusing and needs further analysis, not just the biopsy.
Yes. Last comment, and then we have one question to close the session. I want to also mention that fibrillary glomerulonephritis may present with an MPGN pattern. That's why
Of course.
electron microscopy is very important in these cases. We have a question: is there any correlation sometimes between IgA nephropathy and the MPGN, and when, if it is found? I think it is not a direct correlation. It may be overlap in some of the infection-related glomerulonephritis, maybe in chronic liver diseases. When there is impaired IgA clearance, there will be IgA deposition, and maybe also associated with MPGN pattern on the biopsy, maybe related to hepatitis C virus due to chronic liver disease or whatever. I don't think that there is a direct correlation or overlap. What do you think, sir?
I agree with you, Dr. Muhammad, and I would like to add that, as I've said, MPGN pattern, I think it's some sort of chronic injury. And so if we have an IgA with attacks that had an endothelial proliferation, and endothelial proliferation causes glomerular membrane double contouring, so it will give some MPGN pattern of injury, even in some of the glomeruli. So as we have said, do not rely on the pattern and search for the underlying etiology.
Okay. Again, thank you, Sarah, for this great lecture. We
Thank
have
you.
a question from Dr. Khadija.
Factor H related
Khadija, can you mention your question again, or you can? I will open for you the mic if you want to say it.
Actually, it wasn't a question. I think that I have read one time that when we have a factor H related protein mutation, we can have IgA deposits and macroscopic hematuria in this case. And it is known in some Cypriot population. That's in my memory.
Okay. Thank you, Khadija.
We have to check, yes.
We have another question on the chat from Dr. Wahid Youssef. Based on your cases showing C3 dominant MPGN and C3 glomerulopathy, do you consider alternative pathway dysregulation to be a primary disease driver in a sufficient subset of these patients to justify targeted therapies like factor H-based inhibitors? In other words, is there a clinical meaning from population where pathway modulation would be disease modifying rather than adjunctive treatment? From my opinion, from the clinical point of view, till now there is no, or till now we have only two ways for the management of membranoproliferative glomerulonephritis, whatever the terminologies. Is it immunocomplex mediated disease, or is it related to alternative pathway disease? And as you know, if we have abnormalities in the alternative pathway, we have to know, is it due to autoantibodies, is it due to genetic defect? And according to the pathogenesis, maybe the treatment. And we will find here an overlap between TTP and MPGN, because we have a lot abnormalities, genetic abnormalities in the alternative pathway that cannot be treated in patients who reached end-stage kidney disease. These patients, treatment cannot be done only by kidney transplantation, for example. Some of them may need eculizumab. or liver transplantation. It depends. So we have no clear data about permanent treatment for any abnormalities of the alternative pathway. Maybe the modulation, if there is a discovery for the modulation for the control of the alternative pathway, may cure this disease, maybe. But till now, we have no curative treatment for this disease, even it is a very rare disease. And the drugs are very expensive for the patients in this area. And we have no tools rather than just the complement inhibitors, right, like ocrelizumab or whatever the other drugs. Finally, thank you, Sarah, again for this great lecture. And
Thank you.
see you, inshallah, next month for episode 6, inshallah.
Inshallah.
Goodbye.
مع السلامة.